طريقتهم. السلام عليكم. يعطيكم العافية جميعا. I'm pleased to be with everyone and thank you for the invitation.
Mohmmed, we are vaccinated all. You feel comfortable?
Yeah.
عشان المايك.
You will hear me, don't worry about that. So can I just have the presentation there?
The IT, please.
Yeah.
Okay, so our main objective is to give a brief overview of the rheumatoid arthritis interstitial lung disease and its management. I just want to give you some statistics about the connective tissue disease ILD in the kingdom. We are lucky to be the referral center for the MOH when it comes to ILD at King Fahd Medical City. 2/3 of our patients comes from outside Riyadh, and they are actually coming from all the regions and all the provinces. So I would fairly say that our cohort is representative of what's happening in the kingdom. Connective tissue disease, ILD, account for 25% of the cohort of ILD patients in our clinic, followed closely by IPF at 20%. When we look at the CTD-ILD, rheumatoid arthritis account for 47%, scleroderma 22%, and Sjogren at 14%, then the others, of course. We have 60 patients. 2/3 of them are female. The mean age is 53. Most of the patients are on anti-inflammatory medications or immunosuppressive medications, with 10% of them are also on anti-fibrotic medications. 22% of the patients are receiving oxygen at rest, and 10% of the patients are already following King Faisal Specialty Hospital for lung transplant assessment. In the literature, the usual causes for or subtypes of RA-ILD are the UIP, the NSIP, and organizing pneumonia, and the same applies to our clinic. NSIP is 41%, UIP 37%, and organizing pneumonia at 15%. The RA-ILD can be classified also into a fibrotic type and a non-fibrotic type, and what we mean by fibrosis is that there is fibrotic changes on the CT scan, namely the honeycomb changes, reticulations, and traction bronchiectasis that accounts for at least 10% of the lung field on the CT scan. These fibrotic changes can be progressive, meaning that they are getting worse over time in either the physiologic parameters, so the FVC is decreasing more than 5% over time, the DLCO is decreasing more than 10% over time, or there is increase in the symptoms, so the symptoms are getting worse, namely shortness of breath and cough, or the radiological changes, the extent of fibrosis is actually progressing. The other type of fibrotic disease is the non-progressive type that stabilizes over time. When we look at the estimated proportions of patients with rheumatoid arthritis ILD that manifest progressive pulmonary fibrosis, they are close to 40%. And it is actually the second highest among the CTD-ILD, right after the scleroderma, where the progressive pulmonary fibrosis goes up to 50%. The progressive pulmonary fibrosis concept is very important. The disease or the syndrome itself manifests like IPF in terms of the prognosis. So these patients actually they don't do very well. Similar to IPF, the survival is reduced. The prognosis is poor. The burden of the disease is high. The disability is common, etc. And there is also a therapeutic implication, and that's the reason why I gave you the short overview. In the IMBIL trial, 600 patients with progressive pulmonary fibrosis were randomized to receive either placebo or nintedanib, and they were followed over a 52 weeks period. When we look at the arm that received nintedanib, the rate of decline in FVC was reduced by a relative reduction of 57%. So the patients who were in nintedanib only lost around 80 ml, in their FVC, while the patients who were on placebo lost nearly 200 ml during the study period. So there was a significant reduction in the rate of decline in FVC among the patients who were on nintedanib treatment, and that's why in the latest American Thoracic Society guidelines in 2022, they recommended the use of nintedanib in such patients. When we look at the inbuilt cohort, it was consisted of patients with different subtypes of ILD. The CTD ILD patients comprised 25% of the cohort, and nearly 13% of the cohort were related to rheumatoid arthritis ILD. So the result of this study is applicable to RA-ILD patients. Tikaya looked at the predictive factors for developing RA-ILD in patients with RA. I think we all know about it already. So smoking, positive anti-CCP, and high disease severity score are all important factors, especially smoking. In a systematic review reported by Frazili, he looked into the risk factors that are common in the published trials, and the most common ones were age, male sex, duration of disease, and positive anti-CCP. The management of RA-ILD is complex, and it requires a multidisciplinary approach, as we all know. Education is important, both to the patients and their families. Smoking cessation is key. Drug therapy, and we will discuss that in more details. Pulmonary rehabilitation is important for the rehabable patients. Surveillance and management of comorbidities is also important. In ILD patients, gastroesophageal reflux disease is common. Pulmonary hypertension is also common. The same applies to OSA, pulmonary hypertension, pneumonia, and cardiovascular disease. The vaccination status update is key. Infection is one of the worst outcomes or the worst comorbidities that may occur in RA-ILD patients, and determines the prognosis over time. Unfortunately, we are not doing very well when it comes to vaccination, and if we do not do it in our clinic, no one else will do it. So RA patients are compromised or immune compromised. What we do for them is we give them BCV13, and after 2 to 12 months, we give them PPSV23, that's to cover them for or against the bacterial pneumonia. We advocate for influenza vaccine on an annual basis, and we actually give it in our clinic. And we also recommend giving the COVID vaccination according to the MOH recommendation. Oxygen therapy is important whenever it is indicated, and lung transplantation referral is important. In my cohort, I have 10% of the patients with CTD ILD that already following King Faisal Specialty Hospital. The criteria to refer is easy. So if your patient has pulmonary hypertension and echo, it is time to refer the patient. If the patient is on oxygen, it is time to refer the patient to a transplant facility. The same applies to the patients who have significant reduction in their FVC. So the FVC is less than 50%. The DLCO is less than 40%. Palliative care is also indicated for the patients who require management for their disabling symptoms or who require hospice care when we think that they are not going to live for more than 3 to 6 months. So the first part of the management of RA-ILD applies to the patient who are coming with an acute to subacute presentation. We need to rule out extra parenchymal causes like effusions, pulmonary embolism, and pneumothorax, and then we need to also rule out heart failure and fluid overload. Once that has already been ruled out, we look at the X-ray or CT scan. We expect to see bilateral lung infiltrate in patients with RA-ILD, and at that point we have 4 main differential. Drug-induced pneumonitis is one of them, especially when there is like a recent or relatively recent methotrexate or leflunomide. In the CT scan or the X-ray, there is non-specific ground glass opacities bilaterally. Doesn't usually follow any specific pattern. In some cases, there is a picture of hypersensitivity pneumonitis radiologically. And again, what we do here is easy. We just stop the offending agent and watch the patient for recovery, as most of them do. Some patients with moderate to severe disease would require a short course of steroid treatment. The other differential include rheumatoid arthritis organizing pneumonia. Here there is bilateral, migratory, and peripheral opacities. These patients mostly would require a low to medium dose steroids, so something like 0.5 milligram per kg usually will be enough. Few patients will recover spontaneously without any specific treatment. Infection is important to cover, so we need to cover these patients empirically for community-acquired pneumonia, and we also cover for BJB. The fourth possibility there is acute exacerbation ILD. Under the microscope, the pattern is diffuse alveolar damage, where we see hyaline membrane. These patients do not usually get biopsied, as the mortality when we do biopsy for these patients with acute exacerbation is high, approaching 15% and even more. On the CT scan, what we see is bilateral ground glass opacities and consolidation in the dependent region of the lung, so the lower parts of the lung bilaterally. We do everything for these patients. We discontinue the offending agent, if any. We give high-dose steroid initially. We give empiric antibiotics, including covering for BJB. And this is the most feared, I would say, differential when it comes to the acute and subacute presentation. The mortality rate unfortunately goes up to 50%, which is not very different from the patients with acute exacerbation IPF. The incidence of acute exacerbation, RA-ILD, is around 20%. And as I mentioned before, the mortality is up to 50%. In one observational trial, they looked at the predictors of bad and good outcome in patients with acute exacerbation ILD, and they found that having a UIP pattern on the CT scan was associated with death, while being on methotrexate was protective. So if the patient was on methotrexate at the time of exacerbation, you would probably expect a better outcome based on this observational trial. I will just review recent literature about methotrexate used in ILD. It's controversial, as we all know. So in the European Respiratory Journal, almost 2 years ago now, a case control study designed to examine the association of methotrexate exposure with ILD was conducted. They had cases, like around 400 patients, and a control group. And they found that there was an inverse relationship between methotrexate exposure and the development of the RA-ILD. So the being exposed to methotrexate was actually protective. The other thing that they found was that the incidence of RA-ILD when it happens was delayed significantly in the patient that received methotrexate. So 11%, 11 years in the patient who received methotrexate versus 4 years in the patient who did not receive methotrexate. All in favor of methotrexate. In this nationwide population-based RA cohort in Denmark, a total number of patients of 30,000 were analyzed, and the authors found no increased risk for ILD or respiratory failure. This is the other part of the management. Here we are talking about the chronic presentation of patients with RA-ILD. So the symptoms here are more of chronic, lingering for like several months. If you believe that this diagram is complex, it is modified from a more complex diagram by Yamakawa. So I tried my best to make it a bit simple. The first thing that we look at is whether the arthritis is active or not active, as the key thing to do for these patients to improve the outcome is to control the arthritis itself. So the first thing we ask ourselves is if the arthritis is active, is the ILD itself is subclinical or clinical? Subclinical means that the disease itself is causing mild symptoms or zero symptoms, and the BFT changes are either mild or doesn't exist. If that is the case, we continue in our conventional treatment, so either conventional synthetic DMARD or biologic DMARD. We avoid leflunomide, and the reason behind that is that in studies, they found that being on having pre-existing ILD was the most important factor in leflunomide-induced pneumonitis. So we don't advocate for leflunomide in patients with RA-ILD, even if the RA-ILD is subclinical. The other thing that we have to exert extreme caution with is TNF-alpha. So if you can avoid it, better to avoid it. If you have a stressing need for it, you would have to use it with extreme caution. The reason behind that is there was a recent report that showed increased mortality among patients with RA-ILD who were kept on TNF-alpha. If the ILD is clinical, so it is apparent, it's not just a mild disease, it's moderate to severe in the radiology or on the BFT or symptomatically, then you would use, again, your conventional synthetic DMARD or biologic targeted synthetic DMARD, but with a caveat. So we would suggest not to use methotrexate at this stage, and to use either rituximab or abatacept. Second to that will be the JAK inhibitor. Tocilizumab is less preferred because of the increased aggravation of the disease or exacerbation in patients with tocilizumab. It is still effective. It's a good option, but I would say that it is the fourth agent to pick, and I would prioritize the first three agents, rituximab, abatacept, followed by JAK inhibitor. If the arthritis is not active, then we would look into the lung disease itself, and we would assess the disease with help from our radiology and pulmonary side. If the disease is not showing any progression over time, then we can actually continue on whatever treatment we are giving to our patient with monitoring Q3 to 6 months, mainly with BFT, so FVC and DLCO. If the ILD is progressing over time, we usually take the case to the multidisciplinary discussion round alongside the radiologist and the pulmonologist, and we try to decide if the disease, the ILD itself, is mainly inflammatory or mainly fibrotic. If it is mainly fibrotic, we add nintedanib. We have proof that it works, and this will be consistent with the guidelines made by the American Thoracic Society and the European Respiratory Society. If the disease is mainly inflammatory, then we need to suppress that inflammation. And we have lots of options here. We can do the short-term high-dose corticosteroid followed by a low-dose maintenance corticosteroid. The other option is to add or switch to another DMARD. If we chose to do the short-term high-dose corticosteroid followed by a low-dose corticosteroid, adding the tacrolimus during the maintenance phase has been shown in one study to be efficacious. The other options are, for this specific indication, are the MMF and AZA, cyclophosphamide. Unfortunately, the agents like MMF and AZA are not very good or great when it comes to the arthritis, so we don't commonly use them. On treatment evolution has been evaluated by multiple authors. So we are going to review the main agents here. This is basically how the disease progressed, the RA-ILD over time. So for rituximab, in this one study by Tikaya in 2022, he found that 30% of the patient remained stable. Their RA-ILD was stable throughout the course of follow-up. 10% has worsening of their disease, and improvement was noticed in 35%, which is quite good. For tocilizumab, 33% of the patient had worsening of their RA-ILD while on treatment, and 17% of the patient had improvement. For TNF, 73% of the patient had worsening of their disease over time, while only 7% had improvement, and that's why we don't like to use TNF inhibitor in patients with RA-ILD. Among the conventional synthetic DMARDs, methotrexate showed sustainability in 26% of the patient, worsening of the disease in 16%, and improvement in 29%, and this is a good result and something that we would like to see in our patients. JAK inhibitors was evaluated by Venerito in 2023, a very recent study. His cohort was a group of patients from Italy recruited between the period of 2018 to 2022 in June. He looked at the FVC change over time, the DLCO change in the middle diagram over time, and the high-resolution CT scan change over time. And they found that the majority of the patient, more than two-thirds of the patient, has actually stabilized while on JAK inhibitor. Few patients either improved or worsened. Tardella also published a recent study last year looking into abatacept and the evolution of RA-ILD over time. And they found similar result to JAK inhibitor, except that the number of patients or the proportion of patients with improvement was higher, and the number of patients with worsening was less. The stability was the same. Two-thirds of the patients stabilized on the treatment. So basically, progression of RA in 11%, stabilization in 72%, and RA-ILD improvement in 16% of the patient.
Dr. Mohammed, you have 2 minutes, please.
Yeah. The current smoking habit and the concomitant methotrexate treatment were the two variables related to RA-ILD progression in multivariate regression analysis. I will just use the last 2 minutes describing the risk prediction model that was developed by Kim in 2020. They found 4 variables that help us to predict the prognosis of the RA-ILD and facilitate our discussion to the patients. The variables are age above 60, fibrosis score more than 20, UIP pattern and emphysema. They developed a point system based on these 4 variables, and based on that, you will classify your patient into either stage 1, stage 2, or stage 3. And what this study found is that the predicted 1-year mortality for stage 1, 2, and 3 were 0, 5, and 24%. And they actually tested their prediction model in their derivation cohort and validation cohort, and their assumption or prediction stood true in both the derivation and the validation cohort. To my knowledge, this is the only risk model that is designed specifically to the RA-ILD patient. You can also use the risk prediction model that is used in IPF, and Normi and other investigators have found that the usual risk models that we use in patients with IPF are still applicable to patients with RA-ILD. The easiest one to use is the GAP. So the GAP has gender, age, and physiologic variable, FVC and DLCO. If we take an example, and that's going to be the last thing to discuss. This is one of my patients. His gender is male. His age is above 65. His FVC is less than 50. And his DLCO is between 36 to 55. These are the only 4 parameters that you need to enter to the system. And when you look at the 1-year mortality is 40% here, and the 3-year mortality is 76. When the patients with the RA-ILD die, they usually die because of progression of their ILD. Second to that it will be the acute exacerbation ILD. This is the most common cause of death among patients with RA-ILD. Next to that will be the chronic progression, then the pneumonia and lung cancer. And when you look at the pneumonia in the patients with IPF as a cause of death, it is up to 12%, while in patients with RA-ILD, it goes up to 20%. That's because of the rheumatoid arthritis itself being immunocompromised. Is also another reason why pneumonia is high. That's why vaccination, as we mentioned before, is very important to take care of. And thank you very much.